Aaron, and thanks everybody for joining us tonight. So we'll go ahead and get started here. Anterior hips are kind of near and dear to my heart. I guess I worked as a nursing assistant prior to going to medical school, and was one of the surgeons there. Had just started doing anterior hips and got a lot of exposure early on and kind of stuck. And then just the way life goes, I ended up doing a joints fellowship last year and do a lot of anterior hips as well as knees. But that's why I decided to present on this. So we'll go ahead and get started. Disclosures, unfortunately, don't have any at this point. So first slide here, basically just talking about how prevalent total hips have become. A lot of patients even say that when they come into the office. You know, I never realized how many people have these, and a lot of times people don't understand that or don't know how prevalent they are, and part of that. What's going on?
No sound. Okay. Okay.
Can everybody hear me?
Yeah, it's better now.
Okay. Not sure where we left off, but basically just saying how prevalent total hip and knees as well, but specifically here, speaking about hip replacements, how prevalent they are in the community. So what is a total hip arthroplasty? It's a resurfacing procedure of the hip. So you replace the articular surfaces, one on the acetabulum on the pelvis side, and then the other side on the femoral side by removing the arthritic surfaces in the femur with a stem down into the femoral canal, and then a prosthetic head. So the articulation is happening through prosthetic parts where no more nerve endings or arthritic bone are in contact with each other. So it's essentially, the concept of it is very simple. Basically, you're just removing arthritic bone where the cartilage has worn away, so nerve endings are no longer in contact. The reasons to do a total hip arthroplasty, total hip replacement, there's numerous reasons, but the three main ones are arthritis, which you hear about a lot of. One is osteoarthritis, which is just degenerative, run-of-the-mill arthritis. The other is inflammatory arthritis, which includes rheumatoid and psoriatic, as well as sometimes Lyme disease. Patients with Lyme can develop arthritis. Hip dysplasia, which is the picture to the right there, where it's a congenital deformity, basically where either the femoral head or the acetabulum or both don't form properly. So if you compare the images in the screen, the one on the right, you can see where the acetabulum has formed much more shallow. I don't know if you can see the mouse or not, but it forms much more shallow, which changes how the wear occurs and how the hip moves. So as the cartilage wears away, that becomes more painful because the cartilage itself doesn't have any nerve endings, whereas the bone does. So as the cartilage wears away, it becomes more and more painful. Fractures, so especially in our elderly, more fragile population, you get a lot of hip fractures, femoral neck fractures that can be treated with arthroplasty. And then certain acetabular fractures as well can be treated with arthroplasty. A lot of those are treated by trauma surgeons with open reduction and internal fixation with plates and screws, but certain types in certain patient populations can be treated with total hip as well. So the different approaches, and this is something that kind of has evolved over time. Patients come in a lot of times saying, which approach do you do? I've heard a lot of different things. So the three main approaches that are still used, one is direct anterior, which we're kind of focusing on here tonight. One is direct lateral, which is still utilized by surgeons, I think probably that maybe finish their residencies and trainings in the 80s and 90s, or depending on where you did your fellowship. And then the posterior approach is the other main workhorse. So anterior and posterior are the two main ones, but the lateral is still utilized as well. And then there's several variations of each. So some surgeons will take the posterior approach and make it their own, and just kind of make little variations that they've realized have made the procedure easier for them. The incisions for these, if you look down at the bottom, kind of shows you a diagram. A medial, I haven't seen any patients who've had that approach. That's part of this picture, obviously, but it's one that's not really utilized in adults, sometimes with children, with tendon releases and things like that, done as an early child. They're doing a medial approach. Anterior, obviously, your incision would be in the front of the thigh, right around the area of the groin crease. The anterior lateral here, as it's labeled, is directly over the greater trochanter laterally. And then the posterior approach is more of the curvilinear one you see over the buttock or the posterior aspect of the thigh. So patient awareness. This slide basically is just kind of referring to who's asking me about anterior hips. And it used to be, I think, more so in the younger, more tech savvy, things like that, which those are listed here as well. But it's honestly, it's really picked up a lot of publicity and a lot of attention as the minimally invasive or the new way. And in all reality, it's really not a new approach. It's just something that has been kind of revamped or brought back up in the recent past, in the last 10 to 15 years. But it tends to be the baby boomers, more educated patients tend to ask about it just because they're researching things before coming in. Motivated patients, meaning they've heard, oh, I can get up and start moving faster if I have this done. I want to get back to doing these activities. Young, I kind of put an asterisk there because older patients are now becoming more familiar. And then as going along with the motivated part, some of the more active patients and internet savvy. So patient selection. This is another hot topic with specifically with anterior hip. So the pictures here are they're all large males, but they are large males in different ways, and I'll get into that a little bit more. So ideally, for any joint replacement, we say, if you want to be as fit as possible, obviously, so a BMI of 40 is kind of a rough cutoff, but it depends more so on the body fat distribution and the build of the patient. So there's plenty of patients who come in whose BMIs say that they are morbidly obese, but looking at them, they look like the gentleman in the bottom right picture. So obviously it just depends on muscle mass and build and where the weight distribution is. Even in patients who are obese, a lot of them carry their weight differently. If their abdomen is mobile and you're able to distract it, as you can see in that top image, the surgery itself isn't as big. It's not as difficult as if a patient in the bottom left, where it's more of a firm abdomen that can't get out of the way, and it's harder to mobilize. The hardest anterior total hips to do are muscular patients, because you are going in an intermuscular plane. So you can imagine if you're in that plane and you have larger muscles fighting you on both sides of the interval, it ends up being a more difficult procedure. Hygiene is a big part of this, and that's why a lot of surgeons don't like to do the anterior approach on heavier patients because of skin folds and moisture and sometimes infection risk. Nutrition is a big part of this. So even patients who, were morbidly obese and had bariatric surgery or other ways of losing weight, and they come back with skin issues, excess skin, it's not so much even the skin or the condition of where the incision is going to be. It's more so of a nutritional concern, because just because they've lost weight doesn't necessarily mean they're at a decreased risk of wound healing complications. A lot of the bariatric patients that we treat also have nutritional deficiencies, even though they've lost a lot of the weight and they're overall healthier, which can also set them up for wound issues. And then non-elective cases, basically that just means, patients like I mentioned before with hip fractures who require some form of intervention, whether that be a total hip or a hemiarthroplasty. Sometimes you can treat those with non-arthroplasty options. So the posterior approach, as I showed you the diagram earlier, this is a little, through the intervals that are used, but basically it's a wider exposure. It's a little bit bigger incision. That's a little debatable depending on the surgeon, but typically it's a bigger incision. You're splitting through the gluteus maximus fascia and muscle. You get down to the external rotators, which are the ones that are reflected posteriorly here, but those have to also be released off of the femoral neck and the capsule. So it's a little bit more invasive, meaning you're releasing tendons and muscles off of the bone in order to gain exposure. You also a lot of times need to release some of the gluteus maximus tendon, which can or doesn't necessarily have to be repaired, but so it's just another level of releases that you have to do. So the second bullet there about lower risk of intraoperative fracture, the main reason for that is because you have a wider exposure and you're looking more directly at what you're doing. There's less, there's a greater exposure, so you're not struggling to get the exposure that you need. But until you've done a certain number of anterior hips and the learning curve that you've gotten up on the learning curve, there's definitely an increased risk of potentially fracturing with an anterior approach. That's why this says lower risk through the posterior approach. Lower wound complication risk in certain patients. So as I was mentioning before, with an anterior hip, especially in obese patients with any pannus or skin folds there, it definitely puts you at a little increased risk of having an infection or a surgical site infection or wound complications. The problem with the posterior approach in those same patients is the adipose tissue is much thicker, so that can also cause wound healing issues with fat necrosis, not to mention it's in an area that the patient then is constantly sitting on. So basically, you'll hear arguments either way based on what that surgeon's preference is, but the true answer is you can have wound complications no matter which approach you use. It just depends on the surgeon's preference and comfort and the things that we can do to try to prevent those from happening. So to the anterior approach, and through this diagram too, you can see the interval that's used, which is between the sartorius and the tensor. So the benefit here is that you are going in an intermuscular plane as opposed to having to release the external rotators and split through the gluteus maximus and things like, muscles here. So I would be lying to you if I said you didn't have to release muscle off of the femur to do a hip replacement, because you have to no matter what approach you use. But the number of muscles that have to be released and the extent that they have to be released is significantly less through an anterior approach. So minimally invasive, I always chuckle a little bit when patients ask me that, because if you look at what we're actually doing through a hip replacement, you know, you're removing the femoral head, you're putting a stem in the femur, you're reaming the acetabulum, getting the cartilage. So there's nothing really minimally invasive about it, no matter which way you do it. But from your incision most likely will be a little smaller. The amount of muscle that has to be released is less. So therefore, minimally invasive gets this, becomes a key term that people hang on to. Muscle sparing, as I said, you're not releasing all of these muscles off of the femur. It's more of an intermuscular plane. Faster recovery. So this is the biggest bullet point for me as far as why I do this approach, is that the patients bounce back much, much faster. Now, long-term outcomes are very similar, and that's where the debate comes into the literature, is that surgeons who do posterior approaches, and they've been doing it for years, their patients do great. And same with the anterior approach. It's the short-term recovery that tends to be different. What I mean by that is patients are able to get up with less pain, typically. I mean, there's outliers no matter what approach you use, but typically patients are able to get up with more ease. They do not typically have any of these precautions that you have with the posterior approach, meaning concern for dislocation. So posterior precautions include don't cross your leg, don't bend past 90 degrees. You know, when you're getting up from a chair, don't go past 90 at the waist. So things like that you have to avoid for the first 6 weeks with a posterior approach. You really don't have to avoid that with an anterior approach, because you haven't disrupted the muscles in the back of the hip that are keeping the hip located along with the capsule. So not to say that that you can't dislocate the hip through an anterior approach. You certainly can, but the dislocation rates are lower, and the patients do better in the short term, which they tend to like. So decreased limping, that also goes back to the number of muscles that have to be released, just because it takes a little less time for those muscles and tendons to heal, so you don't tend to get as much of a limp. The lateral approach in particular can cause what's called a abductor lurch, or Trendelenburg sign you may have seen, and that's because the abductors, the gluteus medius that you have to release off of the greater trochanter, sometimes has a difficulty healing, and the nerve can get a palsy as well that may cause inability to level out the pelvis, so you'll end up with an abductor lurch. Allows more anatomic placement. Basically, that bullet point is referring to the fact that we use fluoroscopy during this procedure because the patient is supine and they're on a radiolucent table. We can use X-ray to make sure that we get the cup and the right position as far as the abduction angle and the anteversion of the cup to help prevent dislocation. It also allows us to look at the patient's offset, which is the difference or the distance from the center of the pelvis to the femur, and that helps with hip stability. It also can help prevent trochanteric bursitis and IT band issues, because if you're not looking at that while you're putting the implants in, you can certainly overcorrect that, which can cause troch bursitis, which isn't uncommon after a total hip. Leg length is a big one. That's a big, in the consent for surgery, leg length discrepancy is definitely in the consent as a possibility, but through an anterior approach, as I said, you're looking at the landmarks, so usually look at the lesser trochanters and where they intersect with the pelvis, but you're looking at that in real time so you can make sure that you replicate where you started, or if you're trying to gain length or take away length, you can do that appropriately. So some disadvantages, as I said before. So wound healing complications, I would say that's probably the number one issue that surgeons have with this and that patients end up with, and it does tend to be in the heavier patients or in the unhealthier patients. And this picture shows it well where they tend to happen. It's usually at the top of the incision. It's usually right at a skin fold where you have skin on skin contact and extra moisture. So it's not always an infection. So those are two separate things. So a lot of patients end up with wound healing issues or delayed healing that don't ever have an infection, but having a delay in the wound healing can set them up for an infection. So I typically, in patients that have any pannus or belly, I will treat them prophylactically with antibiotics for a couple weeks until their wound heals. We also check them more frequently to make sure that it's healing. I add some extra sutures there. I very commonly will use an incisional wound vac, which has kind of become more popular over the last few years, and it helps a lot with preventing this type of complication. But it also enables patients who previously may not have been good candidates for this surgery to now be decent candidates for it. Intraoperative fracture, as I said, sometimes getting the exposure you need and can be difficult, especially if it is a larger patient. Technical challenges. So when you're looking at deformities, if they've worn out any of the acetabulum to where you may need customized implants, or if you may need a wider exposure, it can definitely be a little bit more of a challenge until you're comfortable with the approach. And then increased blood loss can happen for several reasons. One, anytime, it's a recurrent theme, I know, but anytime you have less exposure or a narrower interval that you're working in, you can't always see as much as you may need to. So if there's any oozing from behind the femur and you don't have a bigger incision with a lot more exposure, you may not see where the bleeding's coming from. Also, especially early on in the learning curve, as surgeons are learning to do the procedure, they may take a little bit longer. And for that reason, blood loss ends up being a little bit more, because even if there's not any active bleeding, the longer the operation takes, just by default, typically you have to lose a little bit more blood. So how does it work? So the picture here is called the Hanna table. There's actually a couple different variations, but the most common one is called the Hanna. And it's a radiolucent table where your feet are put in what look like ski boots. They are attached to these booms that can be lowered, where the hip can be extended and can be flexed. The feet also rotate so that you can externally and internally rotate the leg as needed. The x-ray at the top there shows you, I typically get a preoperative x-ray to gauge leg length, and that's what the gold line going across the bottom of the pelvis there is you look at where it intersects with the lesser trochanters. So that's my baseline, so that now I know when I finish the surgery, I want those to be at the same place, or at least now I have a reference as to where I want them to end up. But you have an assistant, the nurse or the rep from the company of the implants that you use that are controlling the foot part, since it's outside of the sterile field. Really the only part that's prepped out and sterile is from kind of the iliac crest, or the bottom of the rib cage down to about the knee. That's the only part that's actually draped out. Everything else is behind drapes. So as I was describing earlier, these x-rays, we can look at this and use the x-rays to make sure that the cup's going in exactly where I want it, and that I've reamed to the appropriate depth, and that the neck cut is where we want it. Things like that, that leave a lot less up to through a posterior approach, where you would say, yeah, I think that's about right, or more of an estimation. So looking at some literature, same thing, looking at the different approaches that we just spoke about. This is kind of a funny slide to me, basically because you can find whatever data you want to find. If you are trying to support doing anterior hips, there are countless articles that support doing anterior hips. If you're trying to find data supporting posterior hips or lateral hips, however you want to do them, you can find it. So for anterior hips, these are the summaries and the findings of the papers that you can find. Shorter hospital stay, same hospital stay, no change in operative time, longer operative time, shorter operative time. So the titles of the articles can be misleading. When you actually get into it and read about it, you can find a lot more discrepancy in there. But somebody told me when I was in residency, don't let the data ruin good research, which I still kind of go by. But essentially what I'm just trying to get across here is that the approach itself has many benefits. It has some disadvantages, especially until you're used to doing it, until you get through the learning curve. But overall, the patient recovery tends to be much easier, and they tend to bounce back a little bit faster. I've had a few patients who had a total hip done posteriorly by another surgeon, and then came back for their second hip, and we've done it through an anterior approach, and most of them have said, what a difference. That, long term, they're still doing fine. They're doing well from the posterior hip that they had, but when I see them at the 2-week visit, they say this 2-week period was much easier than it was through a posterior approach. Not all, and this same thing, there are minimally invasive surgery is what MIS. So basically there's some minimally invasive posterior approach where surgeons have started saying, well, I don't release the piriformis, I keep it intact. So then they call it a minimally invasive approach. And that's what I was getting at here, is they're not all created equal. So this diagram is looking at just the muscles around the hip and what they control. And then we'll get into so at the top, so flexion, extension, abduction, adduction, external rotation, and internal rotation. So those muscles are the ones who perform those functions. So now looking at each group individually, so the things that help you with chairs and stairs, so standing up from a chair, sitting into the chair, and then pushing up and down stairs, are mainly gluteus maximus, medius, the hamstrings, and the gluteus minimus. Abduction, same thing, medius, minimus, gluteus maximus, and the piriformis, some of the external rotators, and the tensor. And with external rotation, you can see which ones are labeled there, but those also assist with hip stability. So then when you look at each approach, these are the muscles that end up getting knocked out, or temporarily having pain and having disability to get up and use them through a posterior approach. So the ones involved with stairs and chairs, the ones with stability, the ones with basically just walking. So this is the reason why you have those posterior precautions, because until these heal, you have to be careful with certain activities to prevent dislocation and prevent tearing of the capsule and those muscles that get repaired. Anterolateral, so this is more so what I was referring to earlier as the lateral approach. Same thing. You end up knocking out the gluteus minimus and medius because you release some of those off of the femur, and then you have to wait for them to heal. That's what can result in the abductor lurch. Same with abductors; those are the ones that help level the pelvis, and then internal rotation, the tensor, the medius, and the minimus also help with stability. So through an anterior approach, really the ones that you are temporarily affecting are the hip flexors, and that's the column over on the far left. To an extent, you do get some of the internal rotators with the tensor and the gluteus, but most of the precautions that we give patients after an anterior hip are really just don't do these things for a few weeks until your soreness goes away. It's not because of a concern of dislocation or a concern of complication. It's more so just until their inflammation all goes away, because these muscles are inflamed because we've had to retract them out of the way to do the surgery. So sartorius and the rectus, as well as the tensor, are the three main ones. Iliacus to an extent, but that tends to be a little more proximal. And then the psoas tendon, which is your main hip flexor, is the one where we tell patients try to avoid active hip flexion, especially against resistance for the first few weeks. And then here's a look at those precautions as I was talking before. So traditional hip, meaning posterior approach. So don't cross the legs at the knees for at least 8 weeks. Don't bring your knee higher than your hip. Don't lean forward while sitting. So patients, most commonly when dislocations happen through a posterior approach, I was on the toilet and I went to stand up, and they kind of heave themselves forward and past that 90-degree point, and it levers the hip out. Don't try to pick something up. Getting dressed, I've had a couple patients in the past who, your tendency when you go to pull pants up is you push your knee inward, which is the exact position you don't want, is internal rotation and flexion. So things that are part of most people's daily lives, and you're telling them not to do it or be very careful, it just tends to be a little more difficult for them. Through an anterior approach, like I said, you don't really have any positional precautions. Technically you do, but it's positions that most people would never find themselves in anyway, with their foot externally rotated beyond 90 degrees and their hip extended way back behind them. So, and then limit active hip flexion, as I said, for 6 weeks. And we don't really tell patients not to do it. We just tell them this may be sore for a few weeks, so until your discomfort improves, then avoid it so that you don't flare the hip up even worse. Hip stability. So here's a look at some data about dislocations. So you can read it, the slide itself, but basically out of about 1,700 total hips, the dislocation rate was 1.5%, and it was 0.5% when using 28mm heads. And what that means is total hips are done with multiple head sizes. 28 is the smallest, and in theory and by definition, the bigger head you use, the less risk of dislocation you have. So this is just going to show even the surgeon who did this study with the smallest head that's normally used still had a dislocation rate of 0.5%. And then looking at dislocation rates of other approaches, posterior lateral approach, out of 10,000 hips had a 4% rate. Trans-trochanteric, which is basically I think that's talking about just a direct lateral approach. I haven't had it referred to as that, actually heard it referred to that. That sounds more like an osteotomy, but and then anterior lateral at a 2%. So no matter how you look at it, the rate is much lower. And the other thing is the early dislocation rate. There's some other papers that show it's close to 0. It tends to go up a little bit as time goes on, but those tend to be more traumatic and from an injury. This is looking at implant positioning. So this is a historical paper about cup positioning, and basically they found a safe zone where you want the abduction angle to be somewhere between 20 and 40 degrees, and the anteversion to be somewhere between 10 and 20 degrees, basically. Now, hitting those marks through a posterior approach is difficult because you don't have any way of gauging what you're doing other than the patient's anatomy. So if the patient's anatomy is not what you saw in the textbook, it's difficult to estimate. So the approach the diagram on the right shows you out of this posterior approach, in the center there is where the safe zone was actually hit in the abduction angle as well as the anteversion, and it was only around 20%. If you look at some of the newer papers here, this one, same thing, 780 hips done by 2 fellowship trained surgeons. So this is just showing how they measure the angles, and there's a formula there that they use to measure these based off of the post-op x-rays. But this shows you the same diagram, so you can see how many more were inside of that middle box, which is the safe zone for both anteversion as well as abduction angles. And like I said, this basically is attributable to the fact that we have x-ray. It's almost like cheating, but you have x-ray there so that we can just make sure that we reduce the number of outliers where we put a cup in a position that we weren't planning to. And then same thing here. This just shows as time goes on that those surgeons were improving. So this kind of just showing how there is a significant learning curve to doing the surgery and doing it well, but as time goes on, they were improving in their percentages of getting the implants in the position that they intended to. So then a little bit, I actually added this slide after the fact because I said, well, we're talking about surgery, but a lot of patients that I see, most patients in fact aren't ready for surgery or don't need surgery. So the other treatment options for arthritis, obviously number one is NSAIDs, that's Aleve and Advil, ibuprofen, things like that. Cortisone injections into the hip have gained a lot of popularity recently, not only because they can be helpful in alleviating symptoms, but also because they can help be a diagnostic tool. A lot of patients who come in have knee pain and hip pain and they have a bad back, and it's hard to tell, even though we have x-rays, how much of their symptoms are coming from what. So if we send them for an injection into the hip, they get, even if it's only 2 days, if they get 2 days of relief, then that's a good sign that at least some portion of their pain is coming from the hip. If they don't get any relief at all, then we may need to look elsewhere at their back or their knee or elsewhere. Physical therapy and exercise, I put an asterisk there because I never discourage them from being active and trying to lose weight and trying to do all the normal things, but that can also exacerbate symptoms if they have significant arthritis. So that's why there's an asterisk there. And then patient's mentality. So I harp on this a lot with my patients that just because you have bad arthritis does not mean you need a hip replacement. Some patients say, if I can take anti-inflammatories, have an injection, I don't really care if I have arthritis. Other patients say, I don't want to go on with my life knowing I have something that could be fixed. So you get the whole gamut of some patients start and they go through a progressive treatment from pills to injections to surgery. Other patients say, nope, let's just do it. Let's take care of it. And that's what we do. So final thoughts, common myths about it. The minimally invasive thing I touched on earlier. I think it's definitely less invasive. It's more, it's better tolerated. Patients bounce back faster. But the term minimally invasive, I think, is a little bit of a stretch, in my honest opinion. Smaller incision, same thing. Actually, it's funny, I had a patient today ask me and said, my incision's a little bigger than the one that another surgeon did. And I said, well, that's how it is. I mean, you basically make the incision you have to make to get the surgery done. But even within one surgeon's 100 patients, you'll probably see 20 different lengths of an incision based on the patient themselves. The fact that, or the myth that I can't dislocate or that it will not happen, also, as I touched on earlier, isn't necessarily true. It's just that the rate is much lower and you don't have the same precautions afterwards. And then a lot of patients also ask, is it better? And I can't honestly tell them that it's a better surgery because what actually happens in the surgery is the exact same. It's just a matter of how they bounce back and how the recovery is. So long-term outcomes, typically patients do really well. Hip replacement is the #1 procedure, or the most successful procedure that orthopedic orthopedic surgeons do, mainly because of how much difference it makes in people's lives. And then, but the early outcomes, I think, is what makes a big difference for me and why I do it. Some references for those articles. And I'm not sure how this process works, but I'd be happy to answer any questions if anybody has them.
Thank you, Dr. Garber. That was great. I do have a few questions, and I would like to ask any of our attendees that if they have questions, please type them in the Q&A box at the bottom of your screen. Just hover over that and type it in. But I do have some questions for you.
Sure.
First of all, do you ever have to change your approach once you've either started the procedure or as you're getting to the procedure?
No, I think the biggest issue there is planning and deciding on your approach ahead of time. So if there's a patient that I have significant hesitation about doing an anterior approach due to any number of factors, if they have significant bone loss, or if they have an old fracture, if they have hip dysplasia where they may require a custom implant or something that would be difficult to do through an anterior approach, I typically will just plan to do a posterior approach because you get a wider exposure. But no, I don't think, I haven't ever had to convert over once started. The bigger point there is just trying to identify those patients ahead of time to avoid having to do that.
Mm-hmm. Is the procedure always done in a hospital, or do you also do them in a surgical center?
So do both is the short answer. Most people, and when I say most, it's because basically in my practice right now, a lot of the patients I do them on are not suitable for a surgery center. Mm-hmm. Some of the surgeons in our group have a little bit better candidacy as far as younger patients and thinner patients and more healthy patients that are more suitable for a surgery center, and they do more at the surgery center. But the short answer is more and more people are being done at the surgery center, and they do fine. Most people end up going home the next day from the hospital as well. It's just the higher risk of complication. You want them to be in a more controlled setting.
One of our attendees is asking, for a 60-year-old healthy weight, active with some pain in right hip from osteoarthritis after long walks and hikes, say 90 minutes or more, would it be wise to wait to a certain age or proceed with some sort of evaluation?
I mean, what I always tell patients is an evaluation's not going to hurt anything. I'm probably one of the least aggressive surgeons as far as telling you need to have something done, because the decision should be based on how much it affects your quality of life. So I have patients whose x-rays look horrendous and they do fine with Tylenol. I have patients whose x-rays look not so bad and they are begging to have surgery the next day. So I really just use your films and your exam to kind of confirm what's going on, but the bigger thing is how much it affects your life. So a lot of patients ask, when is the right time? And what most of us say is you'll know. And what that means is when you start saying, I can't go to the grocery store and walk around without taking a break, or I don't go to my kids' games or my grandkids' games anymore because my hip is going to flare up and I know that, and it starts affecting your daily choices and activities, that's when I would say consider something more invasive. But to just be evaluated and get a baseline x-ray, I wouldn't discourage that at all.
Great. And then how much therapy is needed after the procedure?
So most people will go for at least a month. It's typically 4 to 6 weeks. A hip replacement, especially through an anterior approach, is typically much easier to bounce back from than a total knee. So total knees kind of become where the therapy is much more aggressive, and it's much more necessary because they're helping you get your motion back and they're helping push you through some of the stiffness. With an anterior hip, the best thing that you can really do is walk. So once you get on the walker for a week or two and then you transition to a cane and you're off of assistive devices, walking is really the best thing to do as far as keeping the hip mobile, and then you're also training the muscles that you need on a daily basis, they will put you on an exercise bike and have you do certain hip exercises, but it's not nearly as intensive as a knee is.
Couple of other questions. Is the OR time shorter with an anterior hip?
That's completely surgeon dependent. I mean, most of the hips that I do probably take average 75 to 90 minutes. There's certainly surgeons in our group who are faster than that, and then there's surgeons who do posterior hips that are done in the same amount of time. So it really just comes down to what that surgeon is more comfortable with, and how facile they've gotten with that approach. But essentially the answer is no. It's not any shorter of a procedure.
Okay. Someone is asking, how long do the replacements last? I know that, you know, I'd always heard you get about 10 years out of a prosthesis. Is that still the norm, or are they better now?
No, it's significantly better now. The most recent data that we have says that they should last around 15 years, but that data is based off of the polyethylene, which is the plastic liner that goes between the two metal components, from 10, 15, 20 years ago. So we have a newer one that's only been out since around 2010 that is showing to have much better wear rates. So the current estimate that they're giving is between 15 and 20 years. But I certainly see patients every week in clinic who had their hips done in 1992, 1994. So I'm seeing a lot more of the 20 to 25 year range. Most of them are there because they waited too long and they're actually having complications, but I see a lot of them that are 15 plus that are doing fine.
Any other questions from our attendees? Now is the time to ask. I don't see anyone typing. I'd like to thank you, Dr. Garber, for this talk. This was very informative. Thanks to